Hi, I'm Josette Rivera, geriatrician and educator. Behavioral changes are nearly universal in people living with dementia. Almost no one with this diagnosis remains unaffected. Behavioral changes are a big deal. These symptoms might be the first thing people notice, and they can be very distressing. People's lifelong partners, parents, or friends may be suddenly acting in a way that is socially unacceptable or stressful to witness. It's a major reason that perceived quality of life goes down for both patients and caregivers. So what does this look like? Well, there are so many symptoms we might detect in this category. Many but not all are listed here. You can pause now to read them. We will revisit one of these in depth later. It's important to understand that behavioral issues are usually not easily or quickly resolved. As clinicians, our job should be referring patients and caregivers to resources that can help them gain the skills they need to manage these issues. The bedrock of managing behaviors, or what we call the non-pharmacologic approach, is achieved by caregivers changing their behaviors to get a different response from the person with dementia. Caregivers' ability to manage their own energy and mental health is critical as well. Often the best places to learn these skills are in peer groups or community organizations that specialize in dementia and supporting caregivers. Based on others' lived experiences, new caregivers will learn how to modulate their own behavior and de-escalate situations to get a different result from the person they are caring for. There is an entire section on our website dedicated to providing resources for caregivers regarding behavior management. Let's take a moment to dive deeper into a possible scenario. Let's go back to our list of symptoms and look at agitation. Agitation is a bit of a catch-all term and is often used in both clinical settings and by caregivers when reporting symptoms. It comes up a lot. Let's say a caregiver has sent you a message that the person they care for is agitated and they need help. So you call and ask some questions. You might ask, what specifically are they doing and in what context? The caregiver says that the patient, a woman in her late 70s, has been rearranging everything in the bedrooms repeatedly and is hiding food in drawers. This is leading to a rodent problem. When the caregiver takes over and starts cleaning out drawers and tells the patient she cannot do these things, she gets extremely upset and yells, which she never would have done before. Once she even tried to hit the caregiver, and so now the caregiver might quit. After speaking with the caregiver, you talk with the patient. She sounds upset and very worried about how she's going to get everything done and is preoccupied with tasks around the house. The first step, what we've just seen here, is to identify the behavior in detail. What is the behavior? What is the context? And how severe is it? This often requires talking to the patient and caregiver to get perspective on what's happening. And in this case, we've identified that it's leading to a lot of stress for the caregiver. But often we can evaluate the actual behavior too. For example, if someone is rearranging things, that might be okay in and of itself. We might support caregivers by encouraging them to accept a behavior that is not harmful, and we can let go of the idea that that specific behavior needs to stop. The second step is to try to identify triggers. It's important to understand that for people with dementia, behavior can be seen as a form of communication. For example, perhaps this patient cannot clearly recognize or communicate that she has a need, but instead she is irritable in channeling this need through her behavior. Her behaviors may be a response to something she's experiencing internally. So think of triggers. Does the person have a fundamental need that hasn't been met recently? Examples include needing food, water, sleep, or to toilet. The third step is to make a plan and experiment. After identifying some possible triggers, you now have a starting place to try some interventions and see if they work. In our hypothetical scenario, let's say the patient always rearranges things in the early afternoon, but she appears tired. So how might this example play out? The caregiver would lower the shades about 30 minutes after lunch, play some calming music, close the drapes, and turn off the lights. After a few days of trying this, the patient agrees to lie down and work on her projects later. As the patient sleeps, the caregiver removes food from the drawers and cleans them out. And in the kitchen, she puts the food higher up on shelves so it would be out of sight. Each day, the patient sleeps for about an hour and awakens with a continued focus on her projects, but she's less irritable and more easily redirected. "We can finish working in the bedroom tomorrow" becomes a very helpful phrase. This is an ideal scenario. Often several trial and error cycles are needed to see what works. The important part is not to lose hope, keep experimenting, and track the results. Medications have been used for treatment of dementia-related behaviors with varying degrees of effectiveness. If using medications, be clear what behaviors you're targeting with the medication and what success looks like. Sometimes success is defined in conjunction with caregivers. Have a thoughtful risk-benefit conversation about medications with the patient's healthcare decision makers due to their side effects and risks. For details on specific medications and other ways to manage behaviors, please refer to our website. To recap, challenging behaviors almost inevitably come up, so start early by encouraging caregivers to get training and support through peers and local dementia organizations, and be familiar with the non-pharmacologic approach. The 3 steps are: identify the behaviors in detail, identify triggers and possible causes, address them and monitor. Stay at it, and remember, often we need to try more than one approach.